Hello, I'm Tim Briggs, one of the robotic surgeons at UCLH in London. I'm here today to talk to you about robotic radical prostatectomy. There are several treatments for prostate cancer, and the fact that you're listening to this talk doesn't mean that you've been pre-selected to have surgery. Surgery is one of the treatments, but of course there's also radiotherapy, and some patients are suitable for focal treatment. And this is high-intensity focus ultrasound or cryotherapy, which is freezing the prostate. So we would like you to know more about the operation so that if you decide the operation's right for you, you'll be able to make informed decisions about this. And the only way you can do that is by gaining as much information about the operation. You should also see an oncologist in your visit so that you can find out as much as you can about radiotherapy. And if you're suitable for focal treatment, we will tell you that and we'll arrange an appointment for you to see a focal specialist as well. So a little bit about the operation, about how we do it. Well, most of the operations, and by that I mean about 99.5%, are done on the robotic Da Vinci system. The patient gets put asleep on the operating table, and then we place some ports into the tummy. And ports are just like hollow pens. We're able to push some gas in, which we do, and we use carbon dioxide because this is inert, and we blow your tummy up so that you look about 9 months pregnant. But what this does is it gives us the opportunity to put the instruments in safely into your tummy without injuring any bowel. Once we've got all the instruments in position on the Da Vinci robot, the surgeon can operate and move those instruments. So the robot doesn't get on and do the operation on his own. The surgeon drives all the instruments from the console at the side of the operating theatre. So it's like a clever JCB. We move all the instruments. Why the Da Vinci robot is so good is that the instrument that we use has got the equivalent of a human wrist at the end of the instrument. So whatever I can do with my wrist, the instrument can replicate inside you. So that makes certain tasks such as suturing very easy. So that's how we do the operation. What do we do in the operation? Well, this is a diagram through a male patient. This is the bladder. And sitting under the bladder is the prostate, with the water passage passing through the middle of the prostate. There's these little sacs out the back of the prostate called the seminal vesicles. They're not actually part of the prostate, but we remove them at the same time because we think it's the right thing to do. When we excise a prostate, then we remove the prostate here from the bladder, take out the seminal vesicles, we go between the prostate and the rectum, and then excise the prostate right at the apex of the prostate, which is the very lowest part of the prostate here. And then we join the bladder back onto the water passage again. When we've joined the bladder back onto the water passage, we leave a tube in, which is called a catheter, and that stays in for about 10 to 14 days. It's probably the worst part about having the operation, but it's essential because we need to drain all the urine out while that tissue heals. So, there are many complications from operations, but the two that really will concentrate your mind to decide whether you want the operation or not, the first one is continence, and that's urinary continence. And the second one is what happens to your erections afterwards. So, this is a diagram of the picture I've shown you before with the bladder, the prostate, and the seminal vesicles. And there are two little sphincters that control the flow of urine. And a sphincter is like a tap or a valve. And one is at the bladder neck, so that's the bladder neck sphincter or the bladder neck valve. And the external sphincter sitting at the bottom of the prostate. And it's those two that will control your flow of urine, and that's what keeps you continent. So it's the same that keeps a woman continent, but of course she hasn't got a prostate between the two. So when we remove the prostate, we come very close to these two sphincters or valves, and so they will suffer a little bit from that. So straight after the operation, your control of your urine may not be as good as you're expecting. This is the first 70 prostate cases I did on the Da Vinci robot back in 2010. And we asked the patients when their continence was acceptable after the operation. And I got up to a good level, about 92, 93%, but that took about 14 months. Where the curve now is steeper than that, but you will still get some patients at the top who've got a long-term problem. We've got good treatments for that, artificial sphincters and slings. So this is a diagram that we see, or the view that we see during the operation. Here's the prostate with these little seminal vesicle sacs and the vas behind the prostate. And the nerves, if you're looking at if you imagine the prostate's a clock face here, the nerves run down about 5 and 7 o'clock. And there's these hundreds of these little nerves in the tissues. We don't actually see them when we do the operation. It'd be very nice if there was a British Telecom wire running down each side of the prostate, but unfortunately that's not what it's like. So we know where these nerves are, but we do not see them during the operation. But what we do know is if we're going to spare them, we have to get right onto the surface of the prostate. And I know most of you have probably done it, but if you've peeled a hard-boiled egg, you've got the shell, and inside that you've got a flimsy membrane. And if you get that just right, the whole thing just peels off beautifully along the surface of the egg. And that's what we try and do in this operation. This is a diagram of the prostate where the yellow is the prostate, the red is the cancer, and the green the tissue just outside. If we know that your cancer is well away from the edge of the prostate, then we can go in very close to the surface of the prostate. And how do we know this? We know it from your MRI, feeling your prostate, and also from the biopsies. If, however, the MRI or the biopsies or feeling your prostate tell us that there's a chance the cancer may be coming outside the capsule of the prostate, we should go wide. And when I say wide, we're only talking about 3 to 5 millimeters, but that's enough to damage those nerves which give you your erection. But we go wide so that we stay away from that cancer. In this case scenario, the cancer's starting to come out of the prostate, and if we were to go in close, we might leave some cancer cells behind. When you have your prostate removed, it goes over to the laboratory. The pathologists dip the prostate in some special ink, and then part of the examination is to look round the edge of the prostate. And as they look round the edge of the prostate, they will see just benign tissue until they get to here, when they will see cancer right up against that blue ink that they've dipped the prostate in. And so that is what we call a positive margin. And a positive margin is what we're trying to avoid. And the reason we're trying to avoid it is that if you have a positive margin, you've got a higher chance that the cancer may come back. So the PSA, the blood test that you all had, which started your journey here, is not very good at telling us whether a man has got prostate cancer or not. And that's why you went on and had the MRI and then the biopsies. But once we've removed your prostate, the PSA is very accurate at telling us whether there's a problem or not. So if we remove your prostate, your PSA should go down to less than 0.1 and it should stay there forever. If it ever goes up above 0.1 or to 0.2, 0.2, then we assume there's a recurrence and you may need other treatments then. And the chance of your PSA going up, which is what we call a biochemical recurrence, the chance of your PSA going up increases if you've got a positive margin. So I don't want to give you too much sort of medical data, but this study had about 1,600 patients, 1,295 patients, and you can see that if there was a single apical margin, so cancer right just at the apex of the prostate, which is the lowest part of the prostate, the chance of getting a biochemical recurrence, so that's your PSA going up above 0.1, is 13%. If you had a single non-apical margin, the risk of getting a biochemical recurrence goes up to about 19%. And if you have multiple margins, it can go as high as 27%. So you can see we want to keep your chances of getting a recurrence down by reducing the number of positive margins. The other thing that affects the recurrence is also the type of cancer at the margin. If you've got, in this study of over 1,000 patients, if you've got a primary grade 4 cancer with a positive margin, then the chance of your PSA remaining low at 13 years was 74%. With a primary grade 3, it was 90%, and with a negative margin, it was 93%. So there's a big difference between 74 and 93. So that's why we're aiming for negative margins in all our patients. Unfortunately, though, there's a trade-off between sparing your nerves and the oncological outcome. Now, you might imagine now, well, what's this going to mean for me? So every Thursday morning, we have a planning meeting where we plan the operation for each one of you. So we get your histology from your base hospitals, your MRI, and we plot out what we think is the best thing for you. Whether we can spare the nerves on one side, both sides, or on neither side. Whether we do your lymph nodes, whether we can spare your bladder neck, do a retzius, whether we think your sphincter is going to be long enough so that your continence will be all right. So this information is there, it's available for the surgeon who will do your operation. So essentially, we will all do the same thing because we all do what's on the planning sheet. So I can't tell you exactly which surgeon will do your operation, but we will all do what's on the planning sheet. And usually when you talk to the surgeon or see the surgeon in clinic, he will have your planning sheet on our Epic system. So we'll be able to tell you that. So this is really what we do in the planning meeting. Again, we go back to the basic where the yellow is the prostate, the red are the bits of cancer, the green is the tissue just outside the prostate, and the purple discs are the highest density of these nerves that give you an erection. So on this example here, you can see the cancer is starting to come outside of the prostate, and if I try to go in here to spare the nerves on that side, the chances are that if I went in here to spare those nerves, the chances are that I would leave a positive margin there. So on this side, I would have to go wide, and on this side, I could do a nerve spare, because although there's a cancer there, it's well away from the edge, and it's also well away from the greatest density of these nerves. On this patient, he's got two big blobs of cancer, exactly where you don't want them to be. You might think this is unlucky, but 70% of cancers occur in the peripheral zone, which is this lower half of the prostate. So sadly, this is not an unusual scenario. But all we can do here is recommend a bilateral non-nerve spare. In this patient, although there's a cancer and it might be starting to go outside the prostate, it's at the top of the prostate, so it's well away from these nerves. So I would be able to do a full nerve spare on this side and also do a nerve spare on this side with what we call a low release. So coming out through the fascia away from the cancer. So if we can spare your nerves, we do our best to do so, but it's not possible in everybody. Once we've got the planning sheet for you and we can tell you what our plan for you is, we can also tell you what the outcome might be. We know from our previous cohorts of patients that if we do a bilateral nerve spare, so sparing the nerves on both sides of your prostate, the chance of your erections coming back to as they are before the operation with a bit of Viagra or Cialis is about 70%. It is not 100%. If we spare the nerves on one side, the chance of your erections coming back with a bit of Viagra or Cialis is about 40%. And if we don't spare the nerves at all on either side, the risk or the chance of the erections coming back is very low, so 0 to 5%. And usually these patients aren't helped by Viagra and Cialis. So the tablets only help people who get some erections. So Those are the major side effects of this operation, and those are the two things you're going to have to think about carefully before you say that this is the right treatment for you. When you talk to the doctor in clinic or on the phone, I'd also ask you to know what your medication is. Also, know if your past medical history, or certainly tell the doctor if you've had any serious heart, lung problems, if you've had a major abdominal operation, or if you've got glaucoma. The major abdominal operation is because if you've had a big scar on your tummy, inside the bowels and the fat can all stick together, and we don't get that space to put the instruments in. So those patients may have to go on and have an open operation. For men who have just had hernias and appendectomies, we usually manage those, but please do tell us if you've had either of those operations. Glaucoma is high pressure in the eye, and when we do the operation, we put the table into a steep head down, and so if you've got very bad glaucoma, this can put the pressure up in your eye during the operation, and so it might affect your vision afterwards. So most people with glaucoma are fine, but if you've got it, let us know. The worst thing that can happen to you is to turn up on the day of surgery, and then for some reason we find you've had a stroke or you've got bad glaucoma that we didn't know about, and all that will happen on the day is you'll be cancelled until we find out that information. So that's the end of the talk. I hope it's been useful, and when you go to clinic, if you've got any questions from this talk, please feel free to ask the surgeon or the doctor you're seeing in clinic to try and answer those questions for you.